And even if there's a cyst, even if there's a tiniest of solid component, you have to really look at it in great detail if it's harboring a cluster of punctate calcification. And there could be some floating cometal artifacts as well. So those are the things you often observe on the timeline of the thyroid nodule, and which also you have to pick up for any change in the appearance that may warrant FNA and surgery. So peripheral rim, large cometal artifacts again gets a 0. Macro calcification is getting 1 point. Peripheral rim calcification is 2 points. Punctate echogenic foci, are getting 3 points. So coming to the macro calcifications, these get just 1 point. And the tinier calcifications get, punctate calcifications get 3 points. And you can have broken rim calcification is again 3 points. So we have to, broken rim calcifications often indicate there is a pathology is trying to break through. Often in multicentric PTC, like I've had like 3 to 4 nodule also. One side has been removed and the other side's got a 3 to 4 nodule, which shows me tiny specks, which I probably know is also PTC, but still the patient and the clinician has chosen to keep it on surveillance. So because it's a choice between lifetime thyroid hormone therapy versus retaining the whole thing. And if it's a well circumscribed and located well within the thyroid parenchyma, for whatever reason, they've chosen to keep it on surveillance, we have to very precisely map the appearances and the sizes and follow it down. So coming to the punctate calcification, this is of course florid punctate calcification that we can very clearly see. They're just dots. They don't have anything front, left, right, in any plane, any tilt, anything that you do. That's classic of punctate calcification. There's no shadowing. There's no shadowing. They're just dots. Echo dots. That's it. Comet will have some tailing. So angle, move around, figure it out. I'm sure it is possible if you are persistent with it. This is classic punctate calcific foci. Punctate calcific foci. Now you see in this, how is this reported often as missed? Because here the punctate calcification are kind of, like I said, dispersed into the thyroid parenchyma. You don't really have a clear-cut boundary of a thyroid nodule. But how would you report it? You would report it that you see parenchyma appears heterogeneous, and you see probably this could be a nodule at the upper pole, and then you see scattered punctate calcifications within the thyroid parenchyma. So maybe primarily to begin with, there was a small cluster of pathology or a nodule that has gone beyond the boundaries of the nodule, and right now you have it all scattered. So this is another one of the cases which was a missed pathology in outside reporting, which is, of course, there are classic punctate calcification. It is a TIRADS 5. And, like you see then metastasis on the site. Multiple nodules, as the SER TIRADS say, we have to choose the 4 highest scoring, and there are some assumptions, which is pretty much the theory. I, of course, tabulate them, so it makes it easier for the surgeons to understand, because when there is an equivocal FNA, and then you're based on your descriptors, and of course, a lot of the other content that I communicate to my surgeons verbally, they are able to make a better choice for the long-term management of the patient. So this is as per the guidelines given by the ACR as to, depending upon the addition of the scores, when you have 2 points, it's TR2 not suspicious, 3 points mildly suspicious, 4 to 6 moderately suspicious, more than 7 highly suspicious. And of course, my work is in progress to tabulate all the data as to how the FNAs and the appearances and the Bethesda scoring match up together. So recommendations and the size interval and enlargement and any change if the ACR TIRADS level increases between the scans and interval scan is also recommended. So that also actually happens. So you have to take nice images which are in the correct plane and documented, so that across the practices as well, people can compare, because otherwise you are kind of limited to just comparing with your own scans. This is just a simple example This is just because it's a clear cystic, it's anechoic, it doesn't have any echoes within, it's smooth margins, there are no calcifications, it's a TIRADS 1. Now, coming to this. So, these are just simple cases where you can see how would you describe it. So, I see this is the isthmus, I see the right lobe, I see this. So, there is a solid nodule. It's a hypoechoic nodule because this is the background thyroid paragraph. It's solid, it's hypoechoic. Now, these margins kind of appear to me a little bit lobulated. It's not like a smooth, like a haloed margin or something. And see in the longitudinal piece, I just can feel some lobulation. So it's lobulated, I get 2. It's hypoechoic, I give it a 2. It's solid, I give it a 2. And that's the dimension because that dimension is important in the ACR TIRADS scoring as to how to plan the management. So 2 plus 2 plus 2, 6 adds up to 6. TR4 and moderately suspicious. Now, if at all I can pick up any tiny calcific foci in between, I would add that. And of course, the scoring will go to TIRADS 5 then. Now, another important thing which I always do, which my surgeons like, is where is the nodule located in relation to the anterior capsule, the posterior capsule, and the recurrent laryngeal. Even if I think there is no ETE, so I cannot say that it's well located, this much size nodule, it's located well within the thyroid parenchyma or closer to the anterior. Just simply by saying it's located at the upper pole, mid pole, lower pole doesn't communicate that much. They want to know whether, if at all I put it on surveillance, it's likely to grow out, whether it's sitting near the anterior surface, whether it's going to pop out here, or whether it's located very close to the posterior capsule, and it's going to take away the recurrent laryngeal nerve soon. So the posteriorly located thyroid nodules are posteromedially located thyroid nodules are the ones which the surgeons are very wary of, and for which often they have the intraoperative nerve monitoring or a proper counseling of the voice regarding the voice of the patient. And of course, this follicular variant of PTC is histopathology. This another case. Now, this is what? What do you think this is? It is the background is this thyroid parenchyma, which is isoechoic. This is going a shade down, so it's hypoechoic. It's got cystic and solid component. So it's mid-solid cystic component. It's hypoechoic. I don't see any calcifications. The margins, I can't clearly understand. It's not very sharp. I don't think they're lobulated, but it's either ill-defined or maybe well-defined, right? So again, in that case, it's 0. A small speck of calcification that I see here on this edge, I see here, but no more. Nothing inside. I don't think these were punctate calcifications. So, and then, so it gets a score of 5 points, and it's a moderately suspicion. Of course, the biopsy was a Hurthal cell predominance with hista3. So it's in between. So that's when you begin to see that your findings do match the Bethesda and the TIRADS do seem to be going along with one another, then you can understand it better. Now, here, look at this. This could easily be passed on as probably as a benign TIRADS 3 nodule if you do not look carefully at the interior capsule. Because it probably looks like the interior capsule is here and it's the soft tissue nodule is probably popping out, and it was a papillary carcinoma thyroid. Again, now this is multiple nodules are there, tiny nodules. So this is what we call classically multicentric PTC. And you can see there's often has a sub-centimeter multiple nodules. So PTC can be even a 4 millimeter nodule you can pick up. So these are, again, broken calcific rim, very hypoechoic. Now look at the hypoechoic appearances. Very hypoechoic, very hypoechoic. Right? So TR5, suspicious and very hypoechoic. Right? Now, coming to the next, local invasion and lymph node. I'm sure we're all good at diagnosing lymph nodes. That's a full big chapter in itself. Just a simple, that's how the vascularity of parathyroid nodule is. That's a inflamed lymph node. That's a tubercular lymph node. And that's how metastatic lymph nodes look like with calcification or cystic changes or lobular appearances. So this is again, like you can see, isthmus, and this is lobulated margins, hypoechoic, numerous punctate calcifications are there, right? Again, this is again a micropapillary thyroid carcinoma. You have multiple nodules which have got this thing. Now, this is a patient presented with large lymph node metastasis, which was biopsied, and this is a lymph node that you can see. It's got solid cystic component, and it's got these three little dots that I see here. This is a punctate calcification card. This is a spotter. I Anybody would clearly label it as PTC. Now we come to the thyroid. Do we have any clear nodules in this thyroid? No. If we do not have these two pictures, and if you were the person who was doing the ultrasound before these two lymph node metastases happened, would you have picked these up? That's my question to you. This is a retrospectively now trying to find a PTC. Now, when is it a pseudonodule and when is it a real nodule? This is we are trying to get a reverse trail, right? Because there are already large metastases here. But put these aside. Now look at this picture. We see a hypoechoic appearance, which probably appears to me like there's no transverse image. It's not got any clear-cut margins. Like pseudonodular appearance, I'll come to that later, is different. So, and another satellite nodule or this thing that also appears taller. They would have been there in transverse images. So again, this is like close to the anterior capsules. That's why that arrow is there. So these little appearances also, you have to pick them up before you are surprised with large metastatic lymph nodes. Okay. So again, like this is a lymph node. Here, I'm not too sure of the medial capsule. Here, if the medial margin of the trachea. And of course, this has lymph nodes at metastasis. Like this is just a graphic image. So again, we are commonly surprised by large lymph node masses, which are encased in the vessels and everywhere. And and then we are often looking at the primary. Now, my topic was ultrasound approach to thyroid nodules and thyroid scoring. So once we know it's a nodule, it's very easy to do the thyroid scoring. I hope it is, right? Now, whether there is a nodule or whether there is not a nodule, why do people keep on sending us for ultrasound, for the vascularity, for the size, and various other features? Is there any role of imaging in these apart from just filtering out whether there is a cancer or there is not a cancer? There's a significant role of ultrasound imaging. So in cases of inflammatory pathologies, so let's look at that. What are we doing? The size enlargement, I already discussed. Apart from the absolute numbers and the values, and of course, we have to look at the age normograms and the charts. I look at the contour more importantly and the clinical scenario and whether the patient. So these questions go first. Is the patient euthyroid, hypothyroid, or hyperthyroid, and medication and any blood test, thyroid profile, anti-TPO antibodies, and if it's a post-op, the thyroglobulin, those things are basic before I even start my case. Right. So diffuse thyroid diseases happen. You have enlarged gland, isthmus, decreased enlarged isthmus, decreased echogenicity, heterogeneity. Now, this is the kind of picture that we get. So one was nodular spectrum disease, one is diffuse spectrum of diseases. And obviously in real life, both these coexist. That's the interesting part of the whole story. It's not that you are getting diffuse thyroid disorders and there couldn't be any nodules hiding in there, which is a PTC. In fact, Hashimoto's thyroiditis is like the coarse liver is a bad for HCC, the same way it is a soil for thyroid PTCs, right? So, understanding this. So, we have hyperthyroidism, there's a diffuse thyroid enlargement, and it's showing increased vascularity. And we label it and we diagnose it, and then it's be done. So, this is what it is. We do another case, we look at the blood parameters. Look at the amount of coarseness, the vascularity. Vascularity will vary with the stage of the disease, whether the patient has been treated or not treated, activity of the disease. But if you can pick up the fibrotic strands that are there, there's inflammatory nodules, and that lymphoid appearance. the pseudonodular appearance, and the real nodular appearance. Those are the areas that you have to really pick up, and if at all, sampling has to be done over there. Now, so, and also, this is another interesting. See, in this thyroid parenchyma looks all right on the right side, but however, look on the left side, it looks a little hyperechoic and a little bit heterogeneous. So, right side's looking all right. So interestingly, the inflammation can also be one-sided. It needn't be both-sided. It may not be malignant. It may be just inflammatory. That is what it is. In this case, it's a chronic inflammatory inflammatory changes in the one side only. And see, that's the capsule to be able to differentiate. That's the classic. And of course, inflammation. I'm not doing elastography. That's just a picture for reference. Right. Coming to chronic. So Hashimoto's scenario where you have this little fibrotic strands. Now, is there a real nodule in here hiding somewhere that you need to score and that you need to send for FNA? That's the patient that has been sent to you. So you see this little ecogenic strands here. See these ecogenic strands, see these ecogenic strands, and you see these nodules, and you would think that this is a classically called as a Swiss cheese appearance. So it is classic of a Hashimoto's thyroiditis. There isn't anything, and of course FNA. And often you will see when you come down, you'll see these tiny little lymph nodes there in both level 6 position. That of course is a clinical scenario that goes blend in with the same. Right. So again, now in this, like I said, you could get interspersed or scattered microcalcifications and tiny nodule. That's when the picture gets interesting. You pick up those tiny little cluster of calcification and you put in a needle there, you can pick up a PTC there. For example, now in this case, you see these little appearances could be a potential PTC, the timeline of evolving pathology. So those are the areas you have to really be aware, cluster of calcification in the midst of altered ecotexture. That is the challenge. That's where the discrepant reports will dissolve, and with more clarity, you think these three little things dots could be a little bit of the calcification. And this is a classic picture of Hashimoto's with the Swiss cheese appearance and strands. So coming to the conclusion. So thyroid ultrasound evaluation goes, we often jump to, I have patients, like there's an outside report I received a few days ago where there was a TIRADS scoring done of what I thought were pseudonodules. And they said, ma'am, but you have not given the score. The patient came back again. Ma'am, but you have not given the score. They have done the report and they've said it's TIRADS 3, 4, 5, etc., etc. Ma'am, but you've not even told us what is the thyroid score. I said, they have thought there is something that's based on that. Please speak to your doctor. So if I do not see anything, what am I going to score? So a lot of counseling of mine went into this. A lot of counseling of my doctor went into it. So please filter out what is a nodule. First do the diffuse, the size, ecotexture, everything evaluation. Then look at the focal pathologies. And then do their thyroid score. So I have taken you on a journey where the simpler things I put first and the challenging cases I put. And each patient reveals their own unique story. And no two patients are alike, no two thyroid nodules are alike. So it's like you evaluate the detail and it's changing timeline. People come for follow-ups. So of course, care, detail, and experience is required. Thorough reference to the clinical information should be made. Its examination includes, extends beyond the thyroid to complete neck in all cases and includes evaluating an understanding of the parathyroid and the salivary glands and the parotid glands. For me, it does to all of them. The whole area is my work area from the clavicles, jawline, and everything. Of course, choose the correct lexicon and a well-documented report and follow up the case. Try and prepare an Excel sheet in your own desktop and see the follow-ups. And that way you will learn a lot. Talk to your clinician. That's your biggest clue. You really, really learn a lot. And I'm really thankful to the Australia and New Zealand Conference for inviting me to present my first paper, which took me on my journey of my thyroid and parathyroid. Thank you to the IFNOS. Thank you to the ECR, RSNA, and IRIA platform. Thankful to Dr. Jyoti Dabolkar in Head and Neck Journal, who gave me my first publication. From there on, inspired by the work, I went on to write the book on Atlas of Parathyroid. And I really encourage you all. Thank you to Dr. Madan Kapre and Dr. Amit Agarwal and Dr. Anand Mishra at STPGI for inviting me to write chapter in the thyroid textbook, which have been really a great learning experience and sharing it all with all of them. So thank you so much. Learning is a continuous process. I've learned as I've been talking to you today, and I'm very happy to take the questions. Yeah, and thank you.
Thank you so much, ma'am, for the wonderful talk. There are a couple of questions in the Q&A. Are you able to see the tab and see
Yeah,
the Q&A?
there are 23 questions in the Q&A.
No, it's absolutely fine. You may
23.
pick up. Yeah, you
There
may
are
pick up.
23, 25 now. So let me go. So first is, please, ma'am, can we see the recurrent laryngeal nerve? This is an interesting question. My surgeon also asked me. So I've tried to, and I'm not too sure, but I know where it's located. I know when my nodules are bulging. So I give an indication that recurrent laryngeal nerve might be involved. That's the best I am able to do as far as vascularity is not mentioned in ACR criteria. Please opinion, please don't. So exactly, vascularity is not mentioned in ACR criteria, and I do not use it for the thyroid screen. Thank you for your question. Sometimes it's difficult to differentiate thyroid at inferior pole versus parathyroid nodule. Believe me, that's a full talk in itself or a full book in itself. So I will leave that another time, and I would really give a simple option. Please go and buy my book, Atlas of Parathyroid Ultrasound. You will surely learn to differentiate between a thyroid nodule at inferior pole versus a parathyroid nodule. That would be my simple question to that. Of course, a simpler, shorter answer would be there is a capsule, but again, there's a lot that goes into the practice. So, an extrathyroidal, but again, there are extrathyroidal thyroid nodules also. So, that's a simple answer, but that's a full talk in itself. Thank you. Ma'am, what's the management strategy for atypia? Oh, we get so many reports like that. Are you a surgeon or are you a radiologist? Because management is with the clinician. So yeah, management strategy, like I said, with atypia is varies. It's surveillance versus surgery. Then again, that's when my descriptors for the ultrasound imaging appearances really come into play. So my descriptors give them a guide where to go for it. And of course, it's case to case basis of patient's age, choice in life, they want to be on thyroid medication, etc. Many other factors. Please, what do we do if there is obscure calcification? You report whatever it's there in ACR guidelines. If nodules, it's there. If it's obscured, it's written all in the guideline. Thank you. Is wider or taller, ma'am? Oh, will need a context to answer. So yeah, why is it not spongiform? Um, Spongiform, if we just look at the lot of textbook images of spongiform would come by more of an experience that you really label them as spongiform. Please, what is the value of interrupted peripheral calcification? Value. Broken rim peripheral calcification is sinister. It's pointing towards more of malignant pathology towards because it's like the soft tissue pathology is little aggressive. It's like trying to break through the calcific margins. So it is significant finding. It goes towards TIRADS 5. So one second. Yeah. Should you put TIRADS category if found a nodule in the background? Of course, yes, we have to put a background. We have to put a nodule in the background of thyroiditis. It happens. So that is true. You have to. But you have to make sure you are picking up a nodule and not a pseudonodule. So what is a pseudonodule versus a true nodule is another full chapter in itself. Please elaborate about imaging follicular neoplasm. I think that's what we've all done all this time. Please listen to the recording. That's the answer to that. Please, ma'am, what is normal echogenesis of normal thyroid comparable to muscle? Muscle is hyperechoic, and salivary glands have their own unique signature. And do we say that nodule is more echogenic as compared to muscle or that? I mean, to start off, you'll actually choose the thyroid parenchyma itself. Okay. But the thyroid parenchyma itself can also be diseased, right? So you'll take the strap muscles. When it's with the strap muscle level, that's 2 levels down hyperechoic. That's that's how I do it. Yes, ma'am, if nodule is close to capsule and we don't see the capsule, it's suspicious. I mean, if it's close to the capsule and you do not see the capsule, the first thing I would check is the equipment settings, the transducer settings, and your image plane and orientation. Because if you are not in the plane that is seeping through the capsule and you're not oriented, you won't see it. And the capsule is just a location. It's just a scoring. It's not about suspicious or not suspicious. We are just doing TIRADS scoring. We are not doing suspicious or non-suspicious. Please elaborate what is the appearance of thyroid hyperplasia? Thyroid hyperplasia. Um, what's thyroid hyperplasia? What do you mean by hyperplasia? Okay. When to label multinodular goiter? It's enlargement with nodules. That's simple. That's it. And in that, you have to screen each and every nodule, whether it's for its features. That is the task. I mean, multinodular goiter doesn't mean anything. It's just the evaluation of the thyroid. That will come in the descriptor. But then you have to look at the each and every nodule and you have to put in the highest 4 scoring nodules and they have to be sampled and managed that way. Please, ma'am, if you've seen calcification in the background thyroiditis without evidence, it's not then we FNA, because that means that the disease process, if you think this is punctate calcification, I showed you a case specifically for that, right? That you saw the punctate calcification in the background dispersed, and that was a case of PTC. So that means that the pathology is broken through the original nodular appearance and it is spread into the thyroid parenchyma. You have to FNA and you are looking probably at an PTC. Of course, histopathology is the final answer. Are we supposed to differentiate acute versus chronic thyroiditis? Okay, so we have 46 questions. Okay, that's all right. I'm more than happy to take all the questions. Thank you. Are we supposed to differentiate acute versus chronic? Basically, acute thyroiditis, I've really seen a lot of cases in COVID times as well. So many times, even post-COVID also, patients, when they come with like pain and acute symptoms, that's what we clinically per se we call acute thyroiditis, right? And often there would be some level 6 lymph nodes per se, usually inflammatory, tiny, substantive, reactive lymph nodes. And I may see level 2, 3 lymph nodes as well, and may see altered vascularity. Chronic will usually have a diminished vascularity by now and altered or a coarse ecotexture, some fibrotic strands, and that's how it's more of a clinical diagnosis, but imaging wise, these are the features that I see. Okay, so next is does TIRADS advocate high frequency probe for survey of the thyroid? Of course, use the highest frequency transducer because the tiny punctate calcification, the capsular breach, you will only be able to see the higher frequency transducer. I do my cases. There are certain, obviously, even in a busy institute where I work, I may not have the tiny hockey stick available on every machine. It may be shared across the machines, right? So I would move my patient across or get the probe to move across, but I would look at that and then finish off with my final evaluation because those tiny little, even few punctate calcifications, they change the scoring and they change the appearance when it's a Bethesda 3 and I give a TIRADS 5, then a surgeon knows which way to go. If it's a Bethesda 3 and I give a TIRADS 3 or a TIRADS 2, then the surgeon has again a hint as to which way the surgeon has to move on, right? Okay, so that's that. Now, if there are multiple nodules, for example, 4 to 5 in the right lobe and 4 to 5 in the left lobe, Each nodule, yes, definitely. And the ACR says four, four. A few spongiform or classic colloid, though I just label few spongiform or classic colloid. I don't label. And if they are like multiple colloid nodules, I will just write multiple colloid nodules or few colloid nodules or 3 to 4 colloid nodules measuring between so and so sizes are seen. Hello, ma'am. Is localized thyroiditis an entity? How common is biopsy used in thyroid? I mean, patchy thyroiditis, you do have appearance. Like we saw one side, right? You can have that area which is altered ecotexture, right? And if you put it there, you might get a biopsy as a chronic lymphocytic thyroiditis kind of a picture. Yes, of course. You can use a biopsy just to settle down your diagnosis and the patient's diagnosis and just leave it aside. That's another intention of doing it in that case. In huge MNG with multiple closely packed nodules, TIRADS 3, is excision better? That's a clinical call or a surgical call, depending on what patient wants, what's their cosmetic appearance, age, lifestyle, and various other factors. I mean, excision or not excision. TIRADS 3 doesn't decide an excision. It's the histopathology that will guide, and it is the patient's preference that will guide, even though it's benign, whether they want it or not, surgery. And of course, there are lots of surgeries of thyroid happening where they approach through various routes, per oral route, axillary route, mammary route, for cosmesis and various other reasons. So this is entirely between the patient and the surgeon. Are all thyroid nodules fertile? Fertile is basically enlargement, like visible. You can see that's where the word I think came from. But nodules is different. Nodules you can have micro PTC, even that's nodule, and doesn't mean that you're seeing any quadrus enlargement. Please, I sometimes see posterior diffuse hypoechogenicity in normal anterior thyroid. What do they mean? It could be some element of thyroiditis because thyroiditis, it's often posterolateral, the butterfly wing appearance. Those are the areas which are often more patchy and hypoechoic in thyroiditis. So it could mean that. And often, if you do an FNA, you may get lymphocytic changes. Spongiform versus hypoechoic. Spongiform is when you get the classic solid cystic kind of appearance, and hypoechoic when you have the uniform hypoechoic appearance. What's the significance of PSV in thyroid vessels? Of course, I'm doing a research paper with endocrine department for thyrotoxicosis and Graves' disease, uh, 40 to 60, and that's another topic. If patients have MNG with large nodule but small suspicious nodule, which one to assign TIRADS for? It's not about the size, it's about the score. Whichever one you think has got a higher TIRADS score, that nodule, you're not bothered about that, but you can have like ovulations, right? Like ovulation. And spicules are spicules, and ill-defined is ill-defined. That's lobulated margins. Anonymous attendee. Okay, next is how to not call a pseudonodule a true nodule. See, I know you can have something called an ill-defined margins, but pseudonodule is not will not you will not be able to appreciate any margins at all. Uh, and it will be patchy. It will feel like a patchy hypoechoic architecture. It will not be a nodular appearance. Okay. So, template report of thyroid ultrasound, please. Thank you very much. Reporting is the scoring. That's the same ACR thyroid scoring and your descriptors, basically. Role of PSV in thyroid inferno, separate while defined as thyroid 0. That's the thyroid scoring, how it's derived. I'm not creating, I'm just following the thyroids here. Parathyroid adenoma imaging findings. Please read my book. I really want you to. Anonymous attending, parathyroid adenoma. Please buy my book and read it. It's a full topic in itself. What difference between adenoma versus adenomatoid nodule? I don't use the word adenomatous nodule. I don't use the word adenoma. These are histopathological words. These are not imaging words. We are just simply doing this thyroid scoring and using the descriptors here. Ma'am, what should we give in the report with punctate calcification and just altered echo pattern and increased vascularity? Well, vascularity is not a criteria to score it. Altered echo pattern and punctate calcification. If you see a punctate calcification and an altered echo pattern, put it as TIRADS 5 and suggest an FNA. That's all you can do. Vascularity has nothing to do with TIRADS scoring. Only TIRADS is enough in the report, or should we give DD also? What's the DD for TIRADS scoring? I mean, if to do an FNA, what's the DD? It's just a nodule. I think TIRADS scoring is what we are as an imaging. I don't give a DD. What DD will I give? I just thought I would just label what I see, diffuse, what I would just describe my diffuse parenchyma and I would describe my nodules and I would describe the lymph nodes. That's it. That completes it. That's all the surgeon wants to know. What's the significance of isolated isthmal enlargement? I mean, it's an enlargement that can happen anywhere. I mean, it's not, it will obviously give a contour bulge in the interior for cosmesis. Patient may come to you for surgery, but it's not about the enlargement. It's about the inflammation, or it's about the diffuse disease, or it's about the focal nodular disease. So if there's a isthmus, as I showed cases, like there's an isthmus enlargement, but there's a TIRADS 5 nodule in the isthmus and often which is bulging out. So of course it will be managed as per the case, right? It's not about the where it is in the isthmus or right lobe or left lobe. It's whether it's a diffuse pathology, surgery due to cosmesis or various reasons, or surgery due to etc. or any other reason. It's plain microcalcifications versus comet tail will have a tail. Punctate is a dot. Simplest answer. Sometimes you just see calcification without any nodule in the CT, okay, as well as in ultrasound. Calcification without any nodule. What TIRADS is doing? If it's a dense enough calcification that you've seen on CT, I mean, that probably would be a macro calcification without any nodule. That's why we do ultrasound, right? Because whatever, sometimes CT will just pick up a dense calcification, but the subtle boundaries of the nodule, you will pick up on ultrasound. I did show up a case where I couldn't pick up any nodule, but I saw punctate calcifications. These are definite. So of course, I gave it TIRADS 5. So if the calcification is punctate, it's TIRADS 5. If the without any nodule in CTS with ultrasound. So, I mean, without any nodule in ultrasound, that is a little bit of questionable here because I do not know how well you've done the ultrasound. That's why all the one major referral of ultrasound is uh, the incidental nodules that are picked up. So I would really do it very well. There may be an isoechoid, there may be anything. How to identify inferior thyroid artery, that is a topic in itself. Hi, madam. When if we, it's, you'll see it at the inferior pole, superior pole. It's like I can imaging or real time will explain. Hi, madam. If we report a lesion with TIRADS 4 to 5 and the FNAC came back as benign, how do we follow up this lesion? Now, you reported it as TIRADS 4 and 5, basis on what features? That would be more important. Your features are very convincing. Your descriptors are very convincing. Your scoring is very accurate. A. B. The FNAC came as benign. Was the FNAC done on ultrasound guidance or was it done in the pathology as a blind procedure? B. So that's when both of these two have to meet somewhere. How do we follow? Go recheck this, recheck both the TIRADS 5 and the FNAC. That's what I would. That's where all these things come up to me. So there's somebody's reported TIRADS 4 and 5 and FNAC has come back as lymphocytic thyroiditis. Some cases there was a pitfall, there was a comet tail that was reported as punctate. Maybe there was a pseudonodule that was reported as a TIRADS 4, 5 and the FNAC came as lymphocytic. So again, this is the area where you have the discrepant report. So again, you need another opinion. This is where this learning will probably drop down those cases. Thank you. Ma'am, can you show us the exact location of recurrent laryngeal nerve? Go and read anatomy. That's all I would guide you where it's located. So all the nodules which have a posterior-medial extension beyond the capsule of the thyroid, that's where you really need to counsel your surgeon. that look, you counsel the patient on the voice change, because and that's where the level sits and all this area where you often have recurrences, right? So like I've had patients recurrence, they've been operated, but then I've had patients recurrence, I explained earlier. They said, why not getting operated? I said, because surgeon counseled me that I can have my voice or get this out. So I'm just on surveillance. How can I differentiate between rim calcification and eggshell? Eggshell calcification is not a word used anywhere in TIRADS scoring. Rim calcification is and broken rim is used. So eggshell basically, I don't know, would mean basically complete without any broken, or it probably would mean the same thing, but that's not the terminology that we are using. It's just about using the right lexicons. Okay, we have more questions. I think we must have crossed 100 questions.
Ma'am.
Ma'am, you told sponge.
Hi,
Sorry.
ma'am. Sorry, I joined in a bit late. You can skip the questions that you find have already been answered or they're not relevant.
Okay. All right. All right. Let me see. Maybe it was spongiform nodule will become TIRADS 3, but according to this, yes. Yeah, actually, it will become TIRADS 1. So either you just label them as spongiform and let them be aside. But if you do not know, then that is the best you could give your reporting as a, that's what I said. I wouldn't label them as, I wouldn't write spongiform and TIRADS 3. I wouldn't do both of them. It's just what you think it is. If you cannot clear cut be confident that this is the spongiform or TIRAD. Ma'am, TIRADS for solitary macro calcification. I think we have to go to the TIRADS chart for that. Why ill-defined is code 0? That is how by the creators of the TIRADS 5. Follicular versus papillary thyroid sensor or imaging. This is histopathology. I mean, obviously, papillary will have more microcalcification and everything. And follicular adenoma versus follicular carcinoma, as we all have learned in RPG and every time, it's a histopathological diagnosis, right? When to do biopsy of thyroid nodules? Oh, the whole talk was all about that. When do we suspect? Oh, thank you very much. Please listen to the record. That's my answer to you. Thank you. Ma'am, is the new TIRADS dividing 4 to 4 a.m.? I'm still using the original one. That I find that better. Thank you for the compliment. Very insightful. I like that. Is the echogenicity yardstick and strap muscles of thyroid? I go to the strap muscles because thyroid parenchyma will change, but of course your experience will tell you, to be honest. But of course, if it is like the thyroid strap muscles, it's 2 points down. It's very happy. Okay. Thank you for liking us on thyroid. I am blessed and I'm very hopeful that it does cause a change in their practices and we have less discrepant reports around. And I also request you to really read through. So thank you for enlightening. And are parathyroids normally visualized during net scan? Interesting question. Please buy my book. Interesting question. We will meet another time for this. If there are multiple nodules, is it's necessary to give TIRADS? Of course, we talked about this, 4 nodules. Is there any rule of elastography? I am not doing it. There are studies, I talk about it. It's a separate chapter. Ma'am, colloid cyst nodule and spongiform nodule not need TIRADS. Yeah, as per the ACR. Colloid cyst you can, spongiform no. Broken calcification not described in ACR TIRADS. What's photo? It's like basically rim calcification. It's a higher score because I think it's a higher score. Broken rim is a more consistent with TIRADS 4 and 5, and it's often shown me with HISTA 4 or 5 findings. Ma'am, in a case of thyroiditis with suspicious cluster of calcification, what would be our impression when reporting? Suspicious cluster of calcification. If you think there is a suspicion of cluster, that is what you are really looking out. So I would give it a TIRADS 5 and suggest an FNA and an ultrasound guided FNA to really target that area. Do we call a cluster of closely packed punctate foci as macro? No, no, no. You need a high resolution micro ultrasound to break through and really separate the dots. So it's not macro. Macro is different. Macro goes not so benign. Okay, so tiny punctate calcifications are punctate calcification. They are separate. They are not blending together. With solid cystic slash spongiform, hypervascular. Look, vascularity is not a point in here. And with solid cystic, again with solid cystic, is just a criteria. So you have to go by the thyroid scoring chart. So this is like a vague question. So you just have to go by the chart and do the scoring and then go step by step. Thank you. Is it necessary to mention the dimensions? Of course, yes, because did you not see the ACR thyroid says if there's a change in the size, dimension, and there's size criteria on how to follow up the nodules, whether to biopsy or whether to leave them alone. Definitely, you have to mention the size. Oh, okay. The question was the thyroid lobes. Of course, yes, thyroid lobes as well. Because uh, if the thyroid is big or small, if they are taking thyroid medication, if the gland has shrunken, so then where would the relative other anatomical structures be in location in relative orientation to the thyroid parenchyma? That would change. So giving that a clue to the surgeon, and often sometimes people may have a cosmesis preference. So the size will help people go through thyroid from oral route and others as well. So the size criteria really applies in various scenarios. So yes, we will give the thyroid size in all cases. What is pseudonodule? We discussed in the talk. How to differentiate parathyroid from small thyroid nodule? Please buy the book. Sorry. How can I differentiate? That's a total new topic, So how can I differentiate thyroiditis, Hashimoto's, and Graves' disease? We did talk about it. Thyroiditis, we had the cases. We talked about it. Single nodule lesser than 1 centimeter in my Maceron dimension. It's again a case-to-case basis. Go by the ACR TIRADS and what it suggests. What are the nodal stations PTC can metastasize other than, of course, don't you see bilateral cervical lymph nodes level 2, 3, and supraclavicular regions? Yes, so commonly. You have to look at that. Isolated macro calcification, what should be done? Follow up or isolated macro? I mean, go as per the chart scoring. Is there any value of RI values? I don't do them. What about atrophic? Atrophic is basically the gland has gone small post radiation or anything. You just have to give the size and vascularity, and the clinician will manage it. Ma'am, significance of peripheral halo. Halo is not word is not used in benign versus malignant nodules, so I don't use that terminology either. Chronic lymphocytic infiltrate versus Hashimoto's. How to differentiate? Basically, you're looking at a similar ultrasound picture, so it's a histopathological diagnosis. If we have a diffuse thyroiditis involving one lobe, can we label it as? We can suggest it's a thyroiditis, but again, it's a chronic lymphocytic thyroiditis. That is again a histopathological diagnosis, right? In ectopic thyroid, the findings of CA, the thyroiditis will be ectopic thyroid findings of CA. I couldn't please resubmit your question. Findings will be thyroiditis will be same wherever it is. Pseudonodule versus isoechoic nodule with ill-defined rashes. Pseudonodules are usually hypoechoic. They wouldn't be isoechoic. It's like a thyroiditis, patchy hypoechoic ecotexture that has been interpreted as a pseudonodular appearance. How can we get your book? Okay, so I'll share the link. Dr. Chinmay, you share. The book is available on Amazon, and the book is also available from Springer. And you can also buy it from Oliver Bookstore in Mumbai. He's also stocking. And I'm so blessed and impressed to share that I presented my talk at USCON on parathyroid, and the two foreign delegates, Dr. David Fetzer and Dr. N. Kennedy, wanted to read my book, and USCON's gifted them the books. And Dr. Margarita Revson as well. So that's wonderful. So I would really, because that's the only text that's available on parathyroid ultrasound. For me to be able to write 12 chapters on parathyroid ultrasound, just to solve only the dilemmas in parathyroid ultrasound imaging, that's all the book is all about. So I really would like the 3 links, and I'm happy to share the links to Dr. Chinmay. They can share them, and hopefully that transforms the practices and for the benefit of all. Ma'am, even large benign solid cystic nodules show extrathyroidal extension. They are not extrathyroidal. Extrathyroidal is out of the capsule. That's a different terminology uh, than a malignant nodule. So what you're writing, the two things are not correct. So you are writing them as benign first. You've already labeled them as benign. Then you're raising it solid cystic, and they're showing extrathyroidal extension. That is high TIRADS grade. So that's not it. See, just go by the TIRADS chart and simply just apply it. As simple as that. So you do not use the word benign here, and you simply just give the scoring. Let the histopathology speak what it is. Bethesda 1, 2, 3. Next, do you mention likely PTC and impression for classic appearance with micro? I know it, but what I've learned from head and neck conferences and everywhere is that you don't need to write that. You just give the scoring and you give the descriptors, and we know what it is we are looking at. Because ultimately, for us to write PTC is actually not correct because we are writing histopathology in an imaging report, which is not technically correct. So I do not write. I just say TIRADS 5 nodule, likely metastatic lymph nodes, whatever I feel, I write that. Sometimes macrocal with stereoacoustic shadow is seen without any nodule. Yeah, I'm sure, yes. What score to be given? Just mention as macro calcification. Just mention purely as a macro calcification. If you don't see any nodule, I do that. Yes, of course, I do. Thank you. TR4, 5 nodules, 7 size less than 1 centimeter. Please go by the chart. Really say that. Thank you so much. Thank you
Yeah,
so
ma'am.
much.
So much for patiently answering close to 100 questions. You see how popular the topic is, and it's shrouded in controversies, I guess. But I'm sure you've cleared the doubts and got them out of the mud. Uh, sorry, I couldn't join in earlier because of some weather inclemencies. And it was lovely to have you on this platform again. We had more than 450 participants from various parts of the world, and they have loved it.